unfortunately won't be able to join us today. But we will love to nerd out on some medicine. And whoa, I see a whole conference room of people. Hello, MCC5135ZR. Do we know who that is? Can you all unmute yourselves? Tell us more about you.
Hey, how's everyone doing? You guys hear us?
Yes. Hello. Hi, folks.
Hello.
Where are y'all calling from?
We're at Moffitt Cancer Center.
Oh, amazing.
Yeah.
Wonderful. Thanks for tuning in.
No problem. Thank you.
I'm Michael Dowling. I'm joining you from the road in Wytheville, Virginia.
Incredible. Thank you for joining us. Drive safe, okay? Alrighty,
Yeah.
who has a case for us? In the meantime, while y'all think about presenting case, we'd also love for a volunteer discussion. So if somebody wants to jump in and discuss the case, that would be an absolute delight. San Charmin, I'll be going solo. So if we can get a case presenter and discuss it, that would be incredible. In the meantime, I will reflect on the diagnostic journey that we give me. Sorry, I realized that I had my Spotify right here, and I was actually going to hit the play button, so y'all would be listening in to my music playlist. But yesterday was an incredible case presented by Rebecca, a VMR veteran, I would say. And the crux of the case was flank pain. And every time I take care of a patient with flank pain, I'm always humbled. It always takes me to my first ever day as an intern. I was at the San Francisco General Hospital, a very busy community hospital, and I had a patient who would later become my primary care patient who had severe flank pain. And to evaluate for the possibility of a kidney stone, he had gotten a renal ultrasound that was normal. And so the emergency room was super busy and didn't know what he had, but knew that he had too much nausea and too much pain and that he couldn't be discharged. So they signed out the patient saying, hey, you know what, you can think more about him, maybe get a CT. But his ultrasound is negative and his UA is negative. Please help us figure out what is going on. We're way too busy right now to think hard about this. He's too sick. He needs to be admitted. We're like, all right, let's do it. So flank pain. I will tell you, fast forward to now, the most common cause of flank pain I see is musculoskeletal strains and other superficial pathologies like a rib fracture in that region, or as humbling as it is, sometimes zoster with or without a rash. So flank pain is usually a superficial disease unless it represents disease in the kidney, and the most common disease in the kidney is in fact acute obstruction of the ureter, usually resulting in hydronephrosis and pain. So the evaluation of flank pain is usually look at the skin, examine to see if there is palpable pain, which suggests a superficial pathology, and get a urinalysis. A urinalysis is very helpful in predicting stones. What we're looking for on a urinalysis is the presence of hematuria. However, about 20 to 30% of patients with kidney stones have a normal UA without hematuria. So often we often look at the exam, we're like, use the UA to kind of gauge whether or not stones are present and then consider getting imaging. And the imaging of choice is either a renal ultrasound, but better is a non-contrast CT. Non-contrast CT will see kidney stones, no problem. So again, you walk into flank pain, you feel the flank, and if you don't feel anything, it's probably in the kidney. And if it's in the kidney, it's probably a kidney stone. And a non-contrast CT or renal ultrasound is great. Now, yesterday's case was a case of UA negative, non-con CT negative flank pain. What was happening to our dear friend yesterday? I wish I could tell you, I will, but only if we have a case presenter. Please, 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 if you have a case, we need you. We need you. We cannot have more fun without you. So if you have a case, jump on in. And I will tell you afterwards the conclusion of yesterday's mysterious bonanza. But while I put that on hold, I will tell you another story. I'm an intern at the San Francisco General Hospital. And yet again, here we have Mr. Martinez, who has since passed away, who had UA negative, non-con CT negative flank pain, who the ER was too busy to work up, and they signed us out. My very astute resident comes down and notices that he has hypoxemia. His O2 sat is nearly 92%. Why would someone be hypoxemic with flank pain? So I'm going to mute for 5 seconds and would love for you to try to answer that in the chat. Why would someone be hypoxemic? All right. The most common causes are kidney, which we'll go back to, superficial causes, which we talked about, and then the less common causes are if it's on the right flank, a weirdly located gallbladder can definitely do it. If it's on the left side, an infarcted spleen has fooled many of us, including me. And don't forget about the pleura. The pleura goes all the way down to the flank easily. And what Mr. Martinez had, unfortunately, was a horrible empyema. The reason he developed the empyema was he had myelodysplastic syndrome that we diagnosed, and he unfortunately later developed acute leukemia and passed away. A wonderful gentleman who I will never ever forget. Also, as rare causes of flank pain, can the pelvis do it? As Travis mentioned in the chat, ovarian or testicular torsion, ectopic pregnancy, the aorta, and the adrenals. So if you were in the flank, remember the kidneys and the superficial causes. If you're on the right, biliary, on the left, spleen. Don't forget about your pleura on both sides, and much less commonly, pelvis, aorta, and adrenal glands. Okay, I'm gonna learn how to oh man. Okay, who has a case? Anybody? All right, Rafa, my dear friend, always to the rescue. Woo! Who would like to discuss? We just need one discussant and we'll jump in. In the meantime, I will tell you yesterday. Yesterday's case is a different twist. It was UA negative, non-con CT negative flank pain. But the answer is still in the kidney. And remember, there are other things that can happen in the kidney that can cause flank pain. Not just stones, but also pyelo. Not just stones, but also renal cell carcinoma that bleeds. Not just stones, but also cysts in the kidney that can bleed. But probably most morbid of all acutely is infarction of the kidney. The kidneys can infarct because of arterial disease, or the kidneys can infarct because of venous disease. So, yesterday's case, to look for other kidney diseases, the team got a CT with contrast and showed what was a renal artery dissection. So this patient ultimately had a spontaneous renal artery dissection causing renal infarction, causing flank pain. So the biggest takeaway is if you're trying to approach flank pain, feel the flank for superficial causes, and image the flank with non-con if you need to look for stones. After that, if you are in the world of UA negative, non-con CT negative flank pain, it's fun and esoteric, and either you will go to a different organ like the lungs or the biliary tree or the spleen or the aorta or the adrenals, or you will come back to the kidney by getting a CT scan with contrast to look for dissection or renal cell carcinoma or things of that nature. Yes, so great question, Travis. So if there's venous thrombosis, you can definitely get hematuria. Large arterial thromboses sometimes don't connect with the collecting system. So yeah, it's not uncommon to have a renal infarction without hematuria.
You're scaring me with this presentation.
It's scary. It is.
I think I'm going to have to start giving IV contrast to more people to miss this. You know,
but you don't need to. How do you know if somebody has a renal infarct? You get an LDH. So what I do is if it's UA negative, non-con CT negative, get an LDH. And if you were having a renal infarct significant enough to cause flank pain, the LDH will be super high. So that's your clue to help you decide whether you should give contrast or not. All right, y'all. It looks like Rafa's presenting a case, but my dear friend Carl is gonna discuss with me. So, Carl, do you want to unmute yourself and remind the VMR crew of who you are and where you're calling from?
Absolutely. Hi, friends. I'm Carl. I'm a PGY3 at Colorado. And today on my day off from wards, just got back to the gym so the endorphins are flowing and I'm ready to nerd out a little bit more. I'm also applying to rheumatology, so exciting.
Carl, I'm super curious. What's your favorite rheumatological diagnosis?
Oh my goodness. Good
Yeah.
question. Not necessarily an original answer, but I would have to go with ankylosing vasculitis. Just tried and true, right?
Amazing.
Yeah.
I highly second
yeah,
that. Those guys are
just
super
absolutely just curls, Travis. An hour of curls.
cool. And my dear friend Hans, where are you calling from today? How are you? Tell us more.
I'm still stuck where I am in front of my
Yeah.
computer at my mother's house in Germany.
Well, I'm so glad you joined us. Do you have a favorite autoimmune disease to match Carl's ANCA?
A favorite autoimmune disease? I so far I don't. They are all
Okay, all
horrible.
right. Maybe Rafa will give us an option to choose from today. Rafa, hello.
Hi everyone, so my name is Rafael and I'm a last year medical student from Brazil. Always a pleasure to nerd out with you guys.
The pleasure is all ours, my friend. All right, kick it away. And maybe Hans, you can start us off and then we'll go to Carl at the second aliquot.
Okay, so this is a human dex case by Dr. Yasmin Bey. So this is a patient with progressive dyspnea and increased abdominal girth. And that's the end of the aliquot.
Hans, where are you at?
We have progressive dyspnea, an abdominal
Girth.
girth.
GIRF. What does that make you think, my friend? Thoughts, Hans?
I just have to think about what it could be. First of all, we would like to know whether it's sudden or whether it came on insidiously. So that's the timeline. Thinking about an infection or even something like a vascular problem in the abdominal area that might then cause the patient to find it difficult to breathe because of pain.
Beautiful. Yeah, I'm right there with you. I think that
abdominal girth, GIRTH. So that could be like ischemia. So I was thinking. Then difficulty with digestion. Megacolon maybe could be something that we could think of as well as a consequence of Crohn's disease or ulcerative colitis that could cause abdominal girth to increase.
that's beautiful. I love that your mind is trying to solve the abdominal problem first and then connect it to the dyspnea, because I think that you can make much more progress with the abdominal stuff. And I hear you saying in different words, but ultimately the same thing, as what is the nature of the abdominal distension? Is it solid material like increased adiposity or pregnancy or organs? Is it liquid material like blood or ascites, or is it gas? And I think that's the key question. And the truth is that if the patient was right in front of you, you'd probably be able to make an educated guess. If they have liquid in their belly, they usually have liquid in their legs. So lower extremity edema frequently accompanies abdominal distension from fluid. If you just tap on their belly, you will get a sense of whether there's tympany present by the virtue of tympany would help you suspect gas. And so when I'm faced with a patient like this who has a larger abdomen, look at the legs to see the fluid, tap the belly to see if there's gas, and there's nothing, you're probably in adipose tissue. And all of these things you can connect to dyspnea very easily. Anemia, compressive effects of ascites, septic shock from perforation, hepatomegaly from cirrhosis, and portal hypertension. So many connections. So the next step is, what is the nature of the stuff in the belly? Tap it, look at the legs, and if there's nothing else, it's probably solid. All right, Rafa, back to you.
Okay, so this is a female patient, 49-year-old, that presented with a 4-week history of progressively worsening dyspnea. Initially, she only had dyspnea on exertion, but symptoms have progressed to dyspnea at rest. And she also has orthopnea. Besides the abdominal girth, this patient also feels bloated, but has not weighed herself at home. She was recently prescribed a 7-day course of amoxicillin clavulanate for a presumed community-acquired pneumonia. She finished this today and has not noticed any improvement in her symptoms. When it comes to the review of systems, this patient also reports a few months of epigastric pain and nausea without remission in spite of being on pantoprazole, and all the other review of systems was negative. No cough, fevers, chills, night sweats, or changes in appetite. No chest pain at rest or on exertion. No paroxysmal nocturnal dyspnea or nocturnal cough, and no changes in her bowel movements or urine output. When it comes to the past medical history, this patient refers GERD, ulcerative colitis, in remission, not on active treatment. Medications include pantoprazole. She had a colonoscopy 2 years ago with 3 benign polyps removed. She also had a laparoscopic tubal ligation. When it comes to family history, her mother is positive for BRCA1 and BRCA2 mutations. And maternal and grandmother had breast cancer. Maternal grandmother, sorry, had breast cancer. When it comes to the obstetric gynecological history, her menses are regular, with her last menstrual period being 2 weeks ago. She had 2 vaginal deliveries, both uncomplicated pregnancies, and her last pap smear was 2 years ago and was normal. And that's the end of the article.
A lot of information here, Carl. What are you thinking?
You know, just sharing like my immediate thoughts. I'm with Anne Marie. I'm like, just something about this really kind of raises my hackles for like ovarian cancer. Unfortunately, this is a presentation that you hear about a lot, especially in like somebody of this demographic. And with the family history of BRCA, that's certainly highly concerning. But I think stepping back as far as how we conceptualize this and how we work it up, I really at this point want to know if there's ascites there, because that's sort of what I'm most suspicious of. If there is ascites, then obviously we can tap it, work it up, figure out like which bucket we're in, exudative, transudative. If it's not ascites, then we kind of have to think about some of those other things that could cause sort of a mass effect in the belly. But my prediction is there's going to be ascites here, and studying that will really help. And I've definitely got that, got a suspicion for a malignancy that perhaps is involving the peritoneum now.
I love it. I think that that's really up there. I'm curious if you now try to marry that hypothesis with the things that we've learning that describe the syndrome. So it seems like the syndrome features orthopnea and epigastric pain, non-responsive to PPI. Can you marry those two things, or how would they click for you?
Yeah, orthopnea, always raises the possibility of something cardiac. You classically think of that as a heart failure symptom, pulmonary congestion. Certainly, you can have cardiogenic ascites. That's a little bit less common in my mind. And then epigastric pain, unfortunately, is pretty non-specific. That could be anything from like a congestive hepatopathy to just a compressive effect to potentially like a primary upper GI malignancy to just, I think as far as like things that are most specific that'll give me the most bang for my buck working this up, maybe that's a little bit lower, epigastric pain. Although I guess one thing that just came to mind now, like marrying upper GI symptoms, new ascites potentially, and a history of ulcerative colitis, is like PSC. So I'll throw that out there as well to the group. Certainly seeing the labs will help us decide if that could be going on.
I love that. Like, imagine this. Imagine if you didn't get the BRCA, or you haven't in your conversation with the patient gotten to the family history yet. It would be almost impossible to ignore the weight of the history of ulcerative colitis in the background. But as soon as the BRCA stuff squeezes in, all of us, I would say most of us, if not all of us, myself certainly included, ignored the ulcerative colitis. And only after being forced to think about it as part of deliberate practice on my end to like recognize when I'm potentially making an error, and potentially making the error is to assume that everything is coming from BRCA. But I want to acknowledge that it's actually wise to do that. It's wise to say, yo, this case is screaming ovarian cancer. A 49-year-old woman with BRCA1 and BRCA2 in her family coming in with probably ascites and shortness of breath. Like, how is that not ovarian cancer? But the other arm of that, of being better and better at diagnosis, is to like run with that, but then stop and then think about everything else. And I love how you did that. You have to think about ulcerative colitis related complications here, and PSC causing cirrhosis, causing ascites is certainly very important. I have nothing to add to your analysis, but we'll throw in one pearl about orthopnea. How can we play around with orthopnea here without invoking the heart? Orthopnea usually represents a cardiac issue as a result of LV dysfunction. Why? When you lie down, you have increased venous return, the LV is not ready for it, and you feel it. The other less common but important cause of orthopnea is the diaphragm. The diaphragm is aided significantly by standing up, pushing the abdominal contents away from it, allowing it to do its dance without problem. As soon as the patient lays down, now everything in the belly is in the way of the diaphragm and has to do much more work. The diaphragm can fail primarily without secondary disease due to neurologic injury, but can fail secondarily because of too much pressure on it, either because of too much airway pressure or too much abdominal pressure. So, Carl, I think the answer to the orthopnea not being the heart here might just be the ascites. And I just last week had to do a diagnostic paracentesis on a patient with significant ascites, and he couldn't lie flat. Absolutely couldn't. So I think here we probably should chase the heart and think about the heart, because based on the conversation we just had, you can't ignore orthopnea in the heart, but I think it marries well with your hypothesis of ascites and ovarian cancer just through the mechanical effects of compressing the diaphragm. All right, Rafa, let's get more.
Okay, so the temperature was 37. The heart rate was 105. The respiratory rate was 21. The blood pressure was 134/98. She's saturating 95% on room air, and her VMR is 39.7. When it comes to the heart, normal S1, S2, no audible murmurs, no JVG, and no peripheral edema. No JVG, no peripheral edema. When it comes to the lungs, donors to percussion in bilateral.
I think we lost him. Uh-oh. Maybe while we wait for Rafa to rejoin us, Hans, what do you think about the vitals?
The first thing that sticks out would be dullness to percussion. So we might have some
Or
fluids
jaundice noted?
in the lungs. Oh, I think
No evidence.
Hey,
I'm
Rafa,
sorry.
you broke up. Um,
Drogo.
Trying to think, the last thing that we heard were the lung exam.
Can you hear me again?
We can hear you now.
Okay.
Maybe start with your lung exam. You said dullness on percussion. I think that was the last thing.
Yes,
that we heard.
dullness to percussion in
It's gone again.
Huh. All right, Hans, why don't you just tell us about what I mean, I think the exam is obtained serially. So what do you think about the vitals?
Yeah, the vitals itself, heart rate 105, tachypnic, tachycardic because of probably pain and dyspnea itself. Blood pressure seems, yeah, the diastolic is 98. It's a little bit too high, but it's okay. And then respiration 21, and we have on rumor 95% saturation. So it's an indication of her dyspnea and maybe pain that she's suffering as well.
I love it.
BMI 39.7. She's really almost morbidly obese, but this could be because of fluid retention. So I'm not exactly sure that what causes the 39.7. But it could press on her diaphragm, as mentioned before, and secondarily cause the dyspnea and orthopnea.
Beautiful. Beautiful. I love that connection. How are you thinking about the dullness in percussion?
That usually we only see if we have some solid mass in the lung or if there is any fluid accumulation. So she might have fluid accumulation in her lungs, secondary to something else happening.
Beautiful. I completely agree. Carl, what do you have to add to this?
I do think no JVD and no edema, so the absence of both of those things brings cardiac a bit lower on my differential, particularly as elevated JVP has a, is probably the most specific of those, all our physical exam signs for, something cardiac. So
Agreed.
might make that a bit less likely.
Agreed, 100%. I think if you're confident about your JVP exam, which is often hard to actually be sure about, I think you can safely say that without elevated JVP, the amount of fluid this person seems to have in their pleural space seems out of proportion to the JVP elevation. And earlier when we were talking with Hans about the abdominal distension, we were like, is it solid, is it liquid, or is it gas? And we talked about how if you see liquid in the legs, it's probably liquid in the belly. But here we don't see any liquid in the legs. You said there was no peripheral edema. So what does that tell us about the process in the belly? And that's where things get a little bit more complicated, because if the causes of liquid in the belly and the legs are usually systemic causes of transudative fluid in the belly and the leg. What if you see liquid in the belly but no liquid in the legs? That just means that you probably have an exudative or inflammatory process in the belly alone. So said in another way, exudative causes of ascites like TB peritonitis or malignancy don't cause as much lower extremity edema as disease processes such as cardiac ascites, cirrhosis, and liver disease. So here you're like, there's no edema in the legs, so it's probably not transudative ascites. Could it be exudative ascites, or could it be another material like solid or gas? And I think that's when Hans picking up on the fluid in the lungs tells us that this is probably a diffuse fluid process in the belly causing fluid in the lungs. And the absence of edema in the legs suggests that the cause of ascites is likely exudative. And let me pull up a way to think about that. Hans, do you have if we assume this is ascites, Um, if we assume this is ascites, what do you think might be at play?
At this point, I'm not sure because the physical exam, abdomen, soft, non-tender, no bulging flanks, negative fluid wave, no rebound tenderness, guarding, or rigidity. So if we assume that it's somehow exudative, it basically takes place in the thorax, in the chest.
Mhm.
So if it is a malignancy, for instance, as an assumption, then things might have disseminated into the pleural space of the lungs or the thorax.
I love it. Carl, what are your thoughts?
As far as how the exam helps us, I think, I personally, for me, kind of physical exam maneuvers for the presence or absence of ascites, at least in my practice, are just super unreliable. I'm gonna, like Travis said, reach for the ultrasound to tell me if there's ascites in there. So I don't think necessarily the absence of a fluid wave is gonna rule that out for me. And then the lack of rebound guarding rigidity just really tells me there's no peritonitis, there's no like perforated viscous surgical abdomen, but I certainly think there still could be ascites in there.
I completely agree. Rafa just joined us now.
Nice.
I will say that the literature actually backs you up. So there's so much literature out there that our physical exam skills are inadequate to be confident about the presence of ascites. So I will say that the lack of ascites suspected on exam just means you got to whip out that ultrasound, as you said. Rafa, you're back.
I'm so sorry. My computer couldn't handle so much nerding out.
Totally okay.
It was too much for him.
Do you want to give us the rest of the exam? We got the abdominal exam and maybe the labs or the next.
Okay, so when it comes to the skin, no pallor or jaundice noted, and no evidence of spider angioma or capillary medusa. And the musculoskeletal exam showed no signs of cachexia or no thenar or hypothenar wasting. When it comes to the CBC, white blood count 8.3. The hemoglobin was 140, which is normal, 18 grams per liter. And the platelets were 5.5, which is elevated. And the sodium was 135, potassium 4.2, the chloride 100, the CO2 22, the BUN 2.7, and the creatinine 67, which is normal. The liver function test showed ALT of 15, AST 41, ALP 35, GGT 13, the INR was 1.2, and the albumin was 36. And just one exam, the CT chest showed no evidence of pulmonary embolus, but large bilateral pleural effusions.
All right, Carl, where are you at with all this data?
All right. So I think we can safely say this is less likely nephrogenic ascites because renal function is grossly normal and albumin is grossly, is pretty much within the normal range as well. And actually my suspicion for kind of hepatogenic ascites, if you will, or like cirrhosis, portal hypertension is a little bit lower now too. Not absent, but, and I'm saying that not because the LFTs are normal, but really like looking at the albumin and the INR, that tells me the synthetic function is normal. So my probability of like long-standing liver dysfunction is going to be considerably less. And then certainly with the AST, ALT, alk-phos T-Billy being normal, there's no evidence for an acute liver injury either. So this sort of pushes me that much closer to that, my prediction that we're going to find maybe low sag or kind of exudative ascites, if in fact this is ascites. Still want to look at the heart, Still want to see if there's in fact ascites there, but kind of checked off a couple organ systems here.
I I absolutely love that. I think that stands. I have nothing to add to that. It's really a checking off, and it's amazing how good checking off can be to help you zero in on your assessment. So thank you so much, Rafa. Back to you, my friend.
Okay, there are two more aliquots, which will reveal the final diagnosis after those two. I'm gonna reveal just one more, and the serum protein was 69. The serum LDH was 432. And the thoracentesis with fluid studies revealing bloody appearance, fluid protein 56, and fluid LDH 1133. And there's just one more aliquot.
All right, Hans, you're up. What do you think?
Yeah. So this LDH 532 and thoracentesis, bloody appearance, and then an LDH of 1133. It almost makes me think of a malignancy because of the BRCA 1 and 2 positivity. So she might have an ovarian cancer with many question marks. I'm not sure about that. We need a CT abdomen to verify this. But it points like a metastasis of an ovarian cancer.
Beautiful. The fact that the fluid LDH is higher than the serum LDH and the fluid protein is higher than.
Exudative.
Yep, it's exudative. And the causes of an exudative pleural effusion are really the causes of inflammation. So when we're in the world of a pleural effusion, the exudative causes here are either infections, which we don't have prominent signal for, but probably have to consider given the fact that we're diagnosing cancer, autoimmune causes. But really, an exudative effusion in the United States is cancer until proven otherwise. And it's rare that it's a primary cancer of the pleura, like a mesothelioma, and often a secondary cancer, which can be from anywhere. So I agree with you. I think that we have to worry about cancer here. And cancer in a 49-year-old woman, we'd probably have to prioritize many of them. If we use the BRCA as a guidance, we will have to worry about metastatic breast cancer to the pleura. Also have to worry about metastatic ovarian cancer, as folks have suggested. But when you read about BRCA, you'll be humbled as to the number of cancers associated with it. Gastric cancer is also associated with BRCA and may link in the previous epigastric pain that she had. Pancreatic cancer may also link in the epigastric pain and is also associated with BRCA. So here it's hard not to worry about all those four. And as Carl said early on, the abdominal dimension of this and the subtlety of it probably prioritizes ovarian cancer, but you wouldn't be surprised if this is breast cancer, gastric, or pancreatic, or many others. The good news is this yield of cytology is pretty high if you get a lot of samples from the pleural space, and often can be very helpful. So I agree with you, Han. This is exudative, and the concern is cancer. I know there's one more aliquot. So Rafa, do you want to give us that final aliquot for Carl to share his thoughts?
Okay, so the CT abdomen showed extensive peritoneal carcinomatosis. The CA 125 was 1,144. And the CEA was less than 1.8. That's the end of all aliquots.
Alrighty, I find it very fitting, Carl, that this analysis is coming back to you after your very early hypothesis. Where are you at now?
Yeah, I can keep it pretty brief here. So this is a stage 4 malignancy of some kind, assuming it's not like a primary peritoneal cancer, but assuming the primary is elsewhere. This is unfortunately a stage 4. We need to find the primary, and then we need to most likely get our surgical colleagues involved for diagnosis, and our oncology colleagues involved for kind of staging and treatment. But probably ovarian still, if I had to guess.
And my guess is the same as yours. I think radiologists can be confident about what they see. So here they're seeing nodularity on the peritoneum and they're interpreting it as peritoneal carcinomatosis. But the truth is that what they probably are seeing is peritoneal nodularity. And peritoneal nodularity can actually mean a whole slew of different things, but it usually means cancer. You'll be humbled by the number of times peritoneal nodularity outside the United States represents tuberculosis. So that's not the case here, but I just wanted to emphasize how if you take this case and the only thing you change is family history normal, lives in India, this becomes a case of peritoneal TB, basically. So it really hinges on that one piece of data. And how are we more confident that it is ovarian and not breast? Because you could say this is breast cancer going to the peritoneum and going to the pleural space. And that's possible, although when the breast cancer goes into the abdomen, it typically goes into the liver before it goes into everywhere else. So the fact that there's peritoneal disease without liver disease tells you that pattern of spread is more consistent with pelvic tumors. So pelvic tumors go into the chest by crawling through the peritoneum and definitely can involve the liver, but the lack of liver involvement makes breast going to peritoneum a little bit less likely. So Carl, I don't know why I'm talking so much, because you listened to 5 minutes of this case and we're worried about it, worried about ovarian cancer. So I think that is definitely something to be very, very worried about. Hans, any final thoughts before we pass the mic back to Rafa?
Yeah, I think the CA 125, which is a tumor marker for ovarian cancer, more or less gives it away what we might expect. So a CT scan and of the abdomen pelvis should give us the proof.
Yep, I love that. I remember being at a conference with Reza and I discussing a case with 500 people listening in the audience, and I said exactly what you said about tumor markers, and I was humbled. We had a patient. We had a patient then who had very similar case, who had a CA that was a CA 199 that was super elevated, and I said, "Oh, this has to be ovarian cancer." It turned out to be TB, and I learned that these tumor markers are very non-specific. There are only 3 specific tumor markers: PSA, prostate specific antigen; beta HCG in a man or a non-pregnant woman to suggest germ cell tumors; and AFP, alpha fetoprotein, in the context of AFP. Some people can make the argument that SPEP and seropreline light chains, when they're super high, are diagnostic of myeloma, so 3 plus minus 4. But these ones are so noisy and can be falsely elevated. But Hans, in the setting of this case, the pretest probability of cancer is so high that the tumor marker is certainly elevated. My patient, in stark contrast to this patient, was a patient who had no family history, and it was actually from the Democratic Republic of Congo. And so that's why in that case, I think TB was a little bit more likely. But so remember that the tumor markers, there's only 3 of them that are really good. The rest are helpful when they add to an already good case. But I've rambled far too much, and we'll pass the mic to Rafa to take us home.
If you were paying attention, Chiara actually wrote the final diagnosis in the middle of the discussion, but that's okay. So given the peritoneal carcinomatosis and history of ulcerative colitis, the patient underwent a colonoscopy and EGG to assess for gastrointestinal malignancy, which were both negative. The pleural cytology returned positive for adenocarcinoma, an ultrasound-guided mesenteric biopsy was also done, which revealed adenocarcinoma, consistent with a high-grade serous ovarian carcinoma. Genetic test revealed a BRCA1 gene mutation, and she was started on chemotherapy with carboplatin and paclitaxel. For her malignant pleural effusion, she required the insertion of an indwelling pleural catheter. And there's this pearl that I really enjoyed, that peritoneal carcinomatosis refers to the malignant involvement of the peritoneum and can be due to metastatic spread of or due to primary malignancy of the peritoneum. The most common cause with peritoneal involvement include gastrointestinal cancers, colorectal, gastric, and genitourinary cancers like ovary. And there is also this field that we discussed just right now, that CA-125 can be elevated in many non-malignant conditions, such as cirrhosis, pelvic inflammatory disease, menstruation, peritoneal tuberculosis, and pancreatitis, and can also be elevated in other malignancies, such as lung and breast cancer.
Incredible. Any final reflections, Carl and Hans?
I think it's all been said pretty well. You know, I think obviously, unfortunately, she statistically has a very poor prognosis here, and I think you know, obviously, if she has siblings or offspring, you know, genetic counseling is going to be paramount as far as actually taking care of the whole of this patient. But as far as sort of arriving at the diagnosis, no, I don't think I have really anything to add.
I love that. I love that broader point. Thank you. Hans?
Yes, and I have to actually say thank you for the pearl, mentioning that a high CA-125 could also be an infection like TB. I was just thinking too focused to anchor it for malignancy. Was really good.
I think when the case is already high for malignancy, I think that's totally normal to do that. And I'm glad we can learn all these things here together. I learned it as an embarrassing moment in front of 500 people. So I'm glad I could make atone for that a little bit by sharing with you today. All right. Well, Gabrielle, can you take us home with the teaching points, please?
Oh my God, I learned a lot. This was an awesome case. And I think that the thing that I learned the most is how the physical exam is very important to differentiate a lot of etiologies, such as in this case. So for the teaching points, we have this 49-year-old female that presents with increased abdominal girth and dyspnea. So Ravi taught us really well about how the physical exam can help us to differentiate what material is leading to the increased abdominal girth and consequently the dyspnea. So we have the solid, liquid, and gas frameworks. In the solid category, we have things such as pregnancy, hepatomegaly, splenomegaly, and malignancy. In liquid, hemoperitoneum, and ascites. And in case of the gas, such as ileus and obstruction. This patient also had a positive family history of malignancy, especially related to BRCA1 and BRCA2 mutations. So we will start thinking about ovarian cancer that is leading to ascites, and Mario taught us really well. And Mario taught us really well in the chat about how MEG syndrome can explain all this etiology, and also taught us about another related syndrome such as pseudo-MEG syndrome and pseudo-MEG syndrome that I personally had no idea. So for the MEG syndrome, this consists of a triad of ovarian mass, usually benign, plus ascites, plus pleural effusion. Pseudo-MEG syndrome is a non-ovarian tumor plus ascites plus pleural effusion, and pseudo-MEG syndrome consists of ascites and pleural effusion plus elevated CA-125, and it's usually secondary to lupus. The patient also in the history of present illness reported orthopnea. So Carl started thinking about congestive cardiac failure because it's one of the main etiologies that explain this symptom. And the cardiac failure could lead to congestive hepatopathy and then ascites. Also, Ravi told us about other etiologies. If this could be mediated by the increased airway pressure, we could explain this by COPD or asthma. Or if this is mediated by increased abdominal pressure, we could start thinking about obesity, ascites, or another primary neurologic disorders related to the diaphragm innervation. In the physical exam, it was surprising that the patient did not have peripheral edema. So we were thinking that congestive heart failure, that was one of the main causes that we were thinking was less likely. Ravi taught us about that exudative causes are at the top of the list right now, and we can start thinking about some malignancies, especially because they are the most morbid and sometimes carries a bad prognosis. So in the labs, it was noticeable for the evaluation of ascitic fluid that it was bloody and had a high LDH and protein. So we were start thinking about malignancy. And I think one clue that links to that is in the physical exam that, for example, the diminished breath sounds are larger in the right base than in the left. So that is related to Meigs syndrome, because Meigs syndrome usually tends to have right pleural effusion. So in the imaging also we have a peritoneal nodularity. So the differential for that is, for example, peritoneal carcinomatosis. But in the developing countries, we could think about TB, for example, in Peru. And also Ravi told us about to not get biased by the tumor markers because most of them are non-specific and have a non-diagnostic value, but like to evaluate how the patient is evolutioning in the clinical course. There are some tumor markers that are specific, such as the PSA, the HCG in men and non-pregnant women, and AFP. And also Kushal told us about the differential of non-proven antibiotics that we have to keep in mind, such as the run back, drug, duration, diagnosis, and the lack of source control. So thank you a lot of guys for plugging in.
Brilliant, my friend. Thank you so much. All right, I'll see you tomorrow for another round of VMR. Bye.